So welcome everybody. As Lisa mentioned, this is part one of stimulant use disorder. And honestly, please try to come next month if you can. We're going to learn more about really the best evidence-based treatment of stimulant use disorder, which is a behavioral intervention called contingency management. And there's some really remarkable work happening across the state at Spur Wing and the Addiction Resource Center in Brunswick, and Dr. Bauer and I think Christine Wyman are going to come and talk about it. And I think it's really important to sort of understand it and just be aware of it. And there is additional funding, I'm aware of, to expand access to that. So today's sort of more of a conversation about medication management of stimulant use disorder, and then some of the sort of other things you should be thinking about if you're caring for folks with stimulant use disorder. Next slide, please. So we're going to talk about the most recent evidence-based recommendations for med management, stimulant use disorder. We're going to talk a little bit about how to think about a patient that might be in front of you. As people are using more and more stimulants, the risk of sort of tipping into stimulant intoxication is very real. I don't see a lot of it necessarily here, but I see it at the jail pretty regularly. And so it's just important to be aware of how that person might present clinically. So if you did happen to see them, could be, your patient sitting in front of you. It could also be a partner maybe that shows up at the hospital or something. So you're just aware of what that might look like, because it can really be a safety risk for you and for the patient. And then we're going to talk a little bit about harm reduction strategies for individuals with stimulant use disorder, just because this is often sort of a helpless, kind of hopeless feeling patients have. Because there is no such thing as a buprenorphine/Suboxone for stimulant use disorder. So a lot of times people feel like nothing's ever going to make me better. And so there's a lot of kind of ambivalence and sometimes even hopelessness and helplessness. So it's just important to be thinking about all the other ways in which you can intervene on these patients. One of the most exciting things is that there's a new document out, which is the one that I took a picture of here. Sorry, they're getting a lot of notifications here. ASAM and AAP. Whoops, did I just do something? I did. Sorry. Yeah, okay. ASAM and AAP put out a clinical practice guideline, which is like 140 pages long. So you don't need to read the whole thing, but it's really, really helpful if you want to kind of get into the weeds on specific medications. And really the bulk of what I have in here is taken from this new guidance. And it's one of my references as well. Next slide, please. Oh, there you go. So rates of stimulant use disorder are rising, as is stimulant potency, as well as the combination of stimulants with opioids. And so when I'm talking about stimulants here, I'm really talking about cocaine. It could be in the form of crack cocaine or white powder cocaine or methamphetamine, which is probably really what we're seeing more of these days. Overdose death rates increased 3-fold for cocaine and 12-fold for other stimulants, including methamphetamine, in the past 10 years. So a lot of this is really still the fentanyl that's intermixed with these substances, but we're definitely seeing an increase of overdose deaths that have stimulants on board. Beyond the overdose deaths that causes a wide range of health complications, cardiac is probably the biggest, psychiatric, maybe even bigger, and then dental and nutritional complications. We also see a lot of IV drug use. It's very common with stimulant use disorder, so increased risks of things like hepatitis, HIV, and other infectious diseases, particularly endocarditis, which I feel like we see more and more of, which is an infection of the heart valves secondary to IV drug use, typically with contaminated needles or rings. So we're seeing more stimulants, there's more of it available, there's low prices, there's potential contamination of stimulants with the opioids. So there's a tremendous amount of cross-contamination that's really made this a public health crisis. And I think it's really important to be aware of. You have someone with a pure stimulant use disorder, or what you appear to think is a pure stimulant use disorder, just a lot of harm reduction conversation about the fact that there may very well be fentanyl in your stimulants. Same with stimulants in your fentanyl. The number of people who say, no, I just use this, but their urine is positive for 2-3 things is really common. And so if you have somebody who has a stimulant use disorder who doesn't use a lot of opioids and suddenly they use stimulants that are caught with a lot of opioids, that person has a hugely high risk of overdose death from the fentanyl that's in it. So just be aware of that. Next slide, please. All right, so this is sort of the nuts and bolts of the medication management for stimulant use disorder. So none of these are FDA approved, so let's start with that. There are a few studies, small sample sizes, and attrition. So all these recommendations are taken directly from that reference that I talked about earlier in the study. But all evidence is what they call low certainty, so it's a conditional recommendation. So that means there's some evidence out there. We think it's probably good for you to consider trying these medications, but it isn't like kind of the gold standard like an SSRI would be for a mood disorder. So bupropion is probably the one I lean on most. You can 300 milligrams a daily. You can go up to 450 if you need to. We try to use the long-acting one rather than short-acting, in part just because we're trying to keep people's sort of steady serum therapeutic levels rather than sort of having the up and down that really in many ways cause the substance use disorder, because there's a lot of this. So we're trying to keep people more feeling constant and level. There's also typically a mood benefit with it. It's also an activating antidepressant, and a lot of folks who come into treatment miss the sort of energy they had when they were using. And so this one can be a good one to try. Topiramine's another one. I don't use a lot of that here, in part because we don't want to use it in pregnancy. From everything I've read, there is an increased risk of cleft palate. So we don't want to use that one in pregnancy, but it can be used after pregnancy. Slowly sort of titrating it up seems to reduce some of the side effects. There's pretty significant GI side effects sometimes with topiramate. And it also can help with concurrent alcohol use disorder. So it's one to just sort of have on your list. Mirtazapine is one that I actually use pretty regularly. I mean, go up to 30 milligrams a day, sometimes 15, sometimes 7.5. It does definitely help sleep quality, which is one of the major things that we see sort of when people are entering recovery is real challenges with sleep. There also doesn't seem to be any potential for misuse, but it is really associated with a weight gain. And that is one of the things that patients have reported back, like just distress about the amount of weight that they've put on, which is probably related to the mirtazapine. And when you keep in mind, a lot of people who are actively using are like rail thin. And, women have grown attached to that body shape. And so there's a lot of sort of shame that goes into weight gain, and feeling bad about themselves. So it's just something to be aware of and to be thinking about. So baclofen, there's a couple studies out there looking at baclofen. I do want to note that this one was not included in the ASAM recommendation. So this is just sort of really, really off-label, Lane O'Connor's opinion. It's one to think about trying, and you can do 20 milligrams TID. That's a pretty high dose. I usually start something lower, like 5 TID or 10, but it has been associated with reduction in cocaine use. I think of these meds as interchangeable, though. The way that cocaine and methamphetamine behave in the brain is very similar. So I think any of these medications really could be tried for either of the substances. Certainly methamphetamine is stronger than cocaine in terms of the dopamine effect, but any of these meds could be used for either. Modafinil is another one, which for those of you that aren't familiar, is a medication often used for narcolepsy. So it's kind of like a low-level stimulant. I've used it before kind of as I have no other options and I've already thrown the kitchen sink at this problem. Sometimes it works a little bit. There is certainly more of an abuse potential probably with that, but it's like if you have no other choice, it's in the ASAM recommendations as something to try. So just something to be aware of. If they're not on an opioid, extended release naltrexone or oral naltrexone in combination with extended release bupropion can actually have a pretty good effect. I used to use this a lot when I took people out of jail who had a stimulant use disorder. So they would, come out of a correctional facility not having anything in their system, which is very helpful, and then start this. You do want to be sure they don't have opioids in their system, because if there are already opioids in the system, it really needs to be like 7 to 10 days post last opioid use. Otherwise, you'll make them very sick and they'll not like you very much. But it's a good option in certain circumstances. I just want to say that people who you're starting on a medication for stimulant use disorder, it can be pretty effective, when you're getting somebody out of jail, because if they haven't used for 1 or 2 months, to some extent, these medication combinations can help more with the cravings. It is extraordinarily difficult to take someone who's using 3 to 4, grams of some kind of stimulant a day and start a medication and have any kind of meaningful impact. So this would be a case where if you have somebody who's actively using stimulants every day, would be a good person to think about the contingency management that Dr. Bauer is going to talk about, and maybe a medication on top of that. Next slide, please. So this is a very timely topic. This is an ongoing conversation. What about prescribing stimulants for stimulant use disorder? So this is, again, straight from the ASAM recommendations. The recommendations related to the prescription of psychostimulant medications to treat stimulant use disorder, in their opinion, are only applicable to those who are board certified in addiction medicine or addiction psychiatry, or those with basically commensurate training, competencies, capacity for close monitoring. So in the way that it used to sort of be a no, like we really shouldn't consider it. I think now really the tide is shifting, that there are people who can and should consider prescribing long-acting amphetamine or stimulant medications for the treatment of stimulant use disorder. That's really if you feel comfortable, if you feel like you have adequate experience, and really key to be able to monitor that, right? So like this is somebody you're going to want to see pretty regularly, doing drug screens to make sure it's just the stimulant that you're prescribing, not ongoing amphetamine or cocaine. I don't know that I've done it. I don't think I've done it. I just sit in a space where I'm like, but I have used stimulant medications, and ASAM is really clear about this, that stimulant medications should be used for individuals with concurrent ADHD. So 100%, if I have somebody who has diagnosable ADHD that either they came to me with or we help find their diagnosis, I will absolutely use stimulants in those patients. And again, all the same, close monitoring, making sure that urines are appropriate, pill counts, and things like that. But there is absolutely a place for managing the ADHD. I think that's one of the reasons I've seen such tremendous successes, honestly, in my post-jail population, or the population that got out of jail, is that I'm willing to manage things like ADHD with stimulants. And I think a lot of people are uncomfortable doing that. And I've really seen tremendous success stories because finally they're getting the medication combination that people need. But a lot of people are like, oh my God, they have a stimulant use disorder. I don't want to give them anything that they might be able to misuse, which I can understand sort of both sides. But in very significant cases of ADHD, it's really been remarkable how well people have been able to get with the medication. Next slide, please. So co-occurring disorders, it's really important to be aware of any other mood disorders that might be present. You should treat them concurrently, not one or the other. And I wanted to specifically call out ADHD, but there's certainly a number of other mood disorders that you might see. Integrated behavioral health is really essential. I think if you can provide both, that's ideal. I just want to talk a little bit about what you might see in the clinical presentation of someone with a stimulant use disorder. So they tend to be more agitated. This is the description straight from ASAM. I don't love it, but malnourished, disheveled, but is actually pretty accurate. They often appear very, very thin, often appear unkempt or disheveled, typically with mood and behavioral changes. And that's partly a contributing factor, right? They're not eating, they're not really taking care of themselves. In true kind of stimulants, sort of tipping more into this intoxication, you're going to see tachycardia, hypertension, hyperthermia, diaphoresis. I think the hypertension piece I just want to call out because we have definitely seen pregnant people come in with like alarming blood pressure, 180 over 110. And like, is it eclampsia? Is it stimulant intoxication? I don't know, but I'm panicking either way. And so it's really important to take note of that, what the blood pressure is, and it needs management, sort of regardless of what the cause is. You'll see a fair amount of skin picking. People have a sensation that there's bugs crawling on them. That can often be one of the indications for you taking care of them, that they have a stimulant use disorder, is people will sometimes say, well, don't you see the bugs crawling on my legs, or don't you see the things that are biting me? And that can be a good indication that things are not going well. Dental problems are really, really common. It's due to poor oral hygiene, but also decreased salivation. So and that's probably related to buprenorphine too, for people who are on that I think that's part of the contributing factors. People don't have adequate saliva, very dry mouths, which can contribute to poor dentition. And then pacing, repetitive actions, paranoid delusions, hallucinations, mood swings, homicidal or suicidal thoughts. What I'm trying to help you distinguish in this lecture is really being aware that psychosis and significant mood disorders are really common with stimulant use disorder. And there's some that you might feel comfortable managing, but it also can be when people trip totally into intoxication, that you need to be very aware of what's happening in front of you, because people are often acutely paranoid, hallucinating, and it's a real, or homicidal or suicidal. So there's a real risk to you as an individual caring for that patient, and also for your patient themselves. And so just an awareness that can be the clinical presentation. Next slide. Because your job isn't hard enough as it is, right? So just like tip into a little psychosis. All right, so clinical examination should identify any acute concerns, when a higher level of care might be indicated. So those would be situations where there might be tachycardia, hypertension, high temperatures, significant agitation. So you're going to look at the patient, see how they appear, what their statements are, kind of both objective and subjective symptoms. And then again, a safety assessment. And then really, stimulant-induced intoxication is best managed inpatient. And sometimes that patient won't want to go inpatient because sometimes they won't actually even know what you're talking about. So there may be a setting where you need to either get security or other folks involved or get them to an acute care setting, however you need to do that. Labs are necessary. I mean, we see significant cardiac complications, and also folks that are in an inpatient facility are probably better prepared to de-escalate patients as well. That's typically managed with intravenous benzodiazepines. This is not something I've seen a lot of. I've seen the stimulant use disorder that I go, oh God, this needs, treatment in a higher level of care, but I haven't certainly done the intravenous benzodiazepines from an inpatient perspective, but I hear about it from my partners at Portland Fire Department in terms of just very, very high levels of benzodiazepines before they can even begin to sedate a person. Next slide, please. So let's see, if you have somebody kind of with what I think of a low level, the stimulant intoxication that I'm treating on the outpatient basis would be people who are typically using methamphetamine because of the sort of the excessive dopamine release. And these tend to be people who are not, certainly not that clinical presentation of agitated and hyperthermic and totally unaware of their surroundings. Those are not the people I'm treating on an outpatient basis, but you'll get people that come in that start to have a little bit of, changes in their thoughts. You can oftentimes pick up on the paranoia, I would say, is one of the first things. So you'll see sort of subtle changes. Some people will have, they'll take a lot of stimulants. Maybe they'll use more than they've ever used before. They have a different supplier and it's stronger. And they'll have some of those symptoms, and maybe they're even kind of aware of it. And they'll stop using. And actually, if they're tipping a little bit into sort of that paranoia or psychosis, it will often go away on its own if they just stop using the stimulants. But sometimes I manage that with some outpatient medications to sort of help the process. It is important to be aware that people who have stimulant-induced psychosis often go on to develop a primary psychosis in the future. I've seen this last for a longer period of time. When you do have somebody who's demonstrating psychosis, I've seen it last up to 3 weeks. But it then went back to mostly normal, but this is a real risk for people. And I think it's just also important to be talking to patients about the risks of excessive stimulant use. So these are some of the medications you could try if you wanted to. I've used aripiprazole, which I never say right, a couple times, but never like Haldol or anything like that. Next slide, please. So women of childbearing age, just be aware, I'm going to sort of race through this because I think I've already taken more time than I have allotted, but they're not always aware that they can become pregnant because there's a lot of menstrual irregularities. We have really no idea what the prevalence of stimulant use disorder in pregnancy is. It does probably increase the cardiovascular toxicity of the stimulants. And again, you can confuse this. Is it stimulants? Is it preeclampsia? Is it other complications of pregnancy? Doesn't really matter. Deal with it either way. There's a variety of pregnancy complications that we sometimes see: preterm birth, low birth weight. Abruption is the one to be really concerned about. And that I feel like we see frequently in folks with stimulant use disorder. So that can be vaginal bleeding that really requires very quick intervention to reduce the risk of death for both mom and for baby. So all kinds of other complications, infectious disease as well. There's uncertainty around connection between stimulant use and pregnancy and most fetal structural abnormalities due to the many confounding variables that you see. Next slide, please. We do tend to see there's more literature suggesting that stimulant exposure during pregnancy in terms of the long-term effects, so not necessarily the physical changes, but things with self-regulation, attention, basically behavioral changes in children. And it does appear that methamphetamine is more toxic than cocaine. Not surprisingly, it's just a stronger drug. Really critical to retain patients in OUD treatment. I think people are doing this now more than they ever did, but historically it would be situations where people would get stopped. I'm going to stop your buprenorphine because you're using stimulants, which doesn't really help anything. Doesn't help their stimulant use disorder, definitely doesn't help their opiate use disorder, and puts them at a very, very high risk of overdose death. So 100% appropriate that you want to connect these folks with a higher level of care. But that doesn't mean stopping the buprenorphine while you're trying to make that happen. So it's really important to continue the buprenorphine, provided if they're doing any, if they're coming in to see you, if you're having any connection with them, even if they're using copious amounts of stimulants, continue the buprenorphine, unless for some reason they're diverting it, there's none in their system. I mean, there might be a reason to do it. We do want to monitor infants for withdrawal. Breastfeeding is a real risk. Ongoing stimulant use disorder is certainly a contraindication to that. Next slide, please. Associated with increased risk of overdose. This is a very important paper that has been written looking at risk of overdose in pregnant and postpartum people. And really the message here is you can see on the left-hand side, fentanyl is the orange dots that are going up quickly, but the next line below with kind of the light greenish dots are the psychostimulants. And so that is really present more. And then just a reminder on the graph on the right that the risk really is kind of increasing, but it is also late postpartum. So really an awareness that in that sort of 6 to 12 month period, which I think is one of the really important things about the MOM program, that we keep those folks. That is a high risk time. I think it's a really, really high risk time if they've lost custody of their kiddo. Next slide, please. So be thinking about all kinds of secondary and tertiary prevention. So again, I already talked about naloxone, super important, having the conversation about the risks of using alone. Referral to a syringe exchange program if using intravenously. Sometimes drug checking strips, those are actually more accurate than they've ever been in the past. And it can be helpful if you have somebody who's, doesn't have an opioid use disorder. It may be able to identify whether there's opioids in the stimulants that they're using. Safer sex practices, just an awareness of trauma, intimate partner violence. It could be human trafficking. If there's a lot of risky behaviors, at least considering HIV, pre-exposure prophylaxis, dental abscesses and complications. And I think the other thing to remember is stimulant use in general, those folks oftentimes experience appetite suppression. So these are the folks that are really, I've seen some folks come into jail that are, 6 feet tall, 115 pounds, who are just rail thin and haven't been eating really anything. And it could be food security because they're unhoused. It could be they don't, they're not even thinking to eat food. So just an awareness of getting an appropriate diet on board. Next slide, please. All right, so coming next month, contingency management, super exciting, don't miss it. I'm excited for it. You can use pharmacotherapy for off-label treatment of stimulant use disorder. If you're prescribing controlled substances, monitor those patients super carefully. Treat the co-occurring conditions very aggressively because that's going to help with their stimulant use disorder. Assess for stimulant-induced psychosis and just be aware of your own safety as well as that of your patients. Treat the co-occurring psychiatric disorders concurrently along with everything else. And I think the last bullet is just my own sort of soapbox for the day, which is that I'm seeing more pregnant patients experience delays in treatment because of their pregnancy. Like, oh my God, I don't want to do that for a pregnant patient, when it's really, you should be treating. You don't want to use medications in pregnant people that are clearly toxic to a fetus. Like, I'm not suggesting that in any way. But we should really be treating them in the same way that we treat non-pregnant patients, because by delaying their treatment or reducing their access or waiting to talk to somebody about it, and then the patient leaves on a self-directed discharge, you're really doing a lot more harm. So treat them as you would any other woman of childbearing age, and with the safest medications that you can, but certainly don't delay access to treatment. Okay, I think that's my last slide. Sorry, it was long. And there's some good references there. The Clinical Guideline Committee, the second reference, is the one that I mentioned. That's the very recent guidance, and it's excellent guidance. I can only imagine how long that took to write. Okay.
Thank you so much, Elaine.